This is a Renew original recording. Hello and welcome to the Believe in People podcast. My name is Matthew Butler and I am your host, or as I like to say, your facilitator. Today we are here in the lovely Cambridge where we have been personally invited to the home of Professor Dame Carol Black to talk about drug addiction, stigma and of course her recent work in the drug and alcohol treatment field.
So my name's Carol Black and I've been an independent reviewer for the government on a two-part review on illicit drugs. And since the publication of the second part, the government's made me, for the time being, their independent advisor on the misuse of drugs.
I want to ask if you can give us a bit of a summary. You mentioned the two-part report, and I was hoping you could give us a bit of a summary of the report, including the process, the findings, and what some of your recommendations are. If you can condense that. It's a big piece of work, I understand.
It is a big piece of work. Well, just to tell you what it's like to do a review. So the government decides this is a question it wants to ask, or it's a difficult problem. They decide who they want to be the reviewer. They will then ring you up. So Sajid Javid, who was then the Home Secretary, rang me up and said, would I do it? He envisaged a report in two parts. Part one was going to be on supply and demand. Part two would be on prevention, treatment and recovery. When you say yes to a report, you're given a team of civil servants to work with. And for the period of the review, that team is yours. So they don't report into their own director in their department. They report to you. And depending on the topic, the team will be pulled from different departments. So in my case, I had some people from the Home Office. I had someone from several people from Public Health England, the Department of Work and Pensions. You know, people would come into the team who were necessary. And for those months, they worked for you. They got you all the information you needed. You need somebody in the team who is a very good analyst. Need someone who can write well, someone who will make all the arrangements for you to visit centres, prisons, wherever you want to go. So it's usually a team of about 6 or 7, if you're lucky, a few more people, and you work together to produce the report. And you test it as you go along with the different departments, because it's no use producing a report the government isn't going to act on. So you must take everybody you need to support you with you. And that's probably one of the most difficult things, because you often have to keep going back to say, is this okay? This is really what I think should be done. That's the process. So part one was really a market review. So if you think about it, the selling and buying of drugs is like any market. It depends on money. We wouldn't have drug dealers if they weren't making a lot of money out of this. So what we did, we took the drugs wherever they were produced or grown. So heroin from Afghanistan, cocaine from South America, the synthetic drugs that are often made in China or Europe. Of course, cannabis is grown and produced in this country. And we followed their journey to the person who was going to take them. We looked at who controlled those pathways, how much money they made at each step, and who was engaged as they moved down towards the person who was going to buy them and take them. We looked at how much money there was in this market, who made the most money, the damage it did, and really started to think about what were some of the solutions. So really in part one, what I found was it cost the country 19.2 billion a year. Everything to do with managing drugs and the drug trade and prisons and the benefit system. Drug dealers earn about 9 billion a year. So it's a worthwhile market. Absolutely. And we were able to see who was doing it. For example, Albanian gangs control the cocaine market. So you could see exactly where the money was, where it was taken out, and how the drugs were being sold, whether they were being sold directly on the street, whether it was through the post, ordered on social media, etc. And we really saw a very violent and unpleasant trade. And of course, county lines have been developed, which is really a delivery system out from the big cities, often to our seaside resorts, but all over the place, with the runners being young, vulnerable children. So young, vulnerable adults or teenagers usually, often children expelled from school, coming from disadvantaged backgrounds, pulled into the drug trade, and then very badly misused. And of course they might die because there's quite a lot of fighting between drug dealers and those who carry their drugs. And I also found a perfect storm because there'd be more and more drugs imported because the weather was good in Afghanistan and South America to produce the drugs. There was no barriers to them being exported from those countries. So in fact, what was being sold on our streets was purer, therefore more dangerous. And at the same time, we'd had 10 years of austerity, which started politically in about 2013, perhaps a bit before. Money taken out of the drug treatment budget, the police budget, the National Crime Agency budget each year, and therefore less money to really deal with the problem. So it was like a perfect storm. And I described a pretty awful picture. I didn't think the government would find it easy reading, and I didn't think they would give me part 2.
Okay.
Because, I didn't tell them anything that was good at all. I mean, there was nothing good. There were a lot of people trying hard to make the best of it, but everything was going in the wrong way. Drug deaths were going up, murders were increasing due to the drug problem. Serious acquisitive crime driven by drugs was going up. Number of prison places needed for people with an addiction problem was going up. So I thought, well, maybe the government was hoping for a slightly better story. But to their credit, they took it on the chin and said, it's the evidence, you found the evidence. There was a very, very good evidence pack with the review. You couldn't really dispute it. So in part 2, what I did was to really look at the state of treatment and recovery in the country. And to put it very simply, I said to government, it's broken. And if you don't do something about it, you're going to continue to pay the cost of that, i.e., there will be more deaths on the streets, there will be more deaths in treatment, there will be more murders, there'll be more serious crime, and you'll need more prison places.
Absolutely. I think, you're absolutely right, though. What you described, obviously you said it isn't a pleasant story, it isn't a pleasant read for them to hear, but you painted the picture of something that is the reality. And I think that's one thing that a lot of people especially the public, don't necessarily realise when they see someone with substance misuse issues. They just see the symptoms of the addiction, not necessarily the signs and everything else that they're going through. To backtrack a little bit, when you said about basically you was given a team, was you able to choose the team, or is that a team that's provided to you? Because I imagine that makes it a little bit more difficult being told, here's the staff that you're going to be working with, as opposed to you finding the right people for the job.
Well, you see, you don't really know how to find them. I mean, you have to. What you have to do is see who they want to give you, and then you talk to those people and you try to make an assessment about whether the skills they have will be okay for what you think you've got to do. So, for example, if you're looking for someone who knows how to write, because you need somebody all the time to be recording, to be writing, and somebody's going to write the first draft, because the team likes to produce this. So if they offer you somebody who's never written anything more than 4 pages long, Well, I think you would go back, and I have gone back to them and said, I don't think this is really perhaps somebody with enough experience. Yes, very bright, very good. But is this going to be enough? For me, I have, as I've done the review, asked for extra help.
Yeah.
As you do it, you see things you didn't know you needed.
Mm.
And
Until you realise you need them.
You didn't realise you needed them until you were into the review.
Yeah.
Usually you get a very good response. It's usually not a problem because, after all, they need a good review.
So you talk about you had a call directly from Sergeant David. You've done work with the Prime Minister before. Was it David Cameron? Tell us a little bit about, I suppose, the process of that.
The head of the department that's going to commission it.
Yeah.
So it would be
sense.
like Matt Hancock for part 2, Sajid Javid for part 1.
Okay.
But then I was lucky enough to be able to discuss the findings in a meeting with the Prime Minister. So I had the pleasure of meeting many of the ministers. I think the easiest way when you're dealing with people who are very busy, as politicians are, you really need to have really decided what are the essential things you need to tell them and what is it you're asking them.
Yeah.
Because they can always get their team to give them the extra facts. So you don't go burdening them with everything you did to ever get there. You give them the really hardcore information that tells them where the country is on this particular problem, and then say, and these I think are the solutions. This is what I think we should do. But you need to keep it very simple.
Of course, yeah.
Because, they have to take in so much stuff.
Yeah, I can understand that. What's it like in terms of, is there a negotiation part there on your part in terms of the work you do, or do they just sort of say, here's the work I need you to do and come back to it? Or?
They suggest terms of reference, and you can push back on them. So, for example, there were 2 specific things they decided to exclude from my review. One I was quite comfortable with. The second, in retrospect, I wished I'd pushed back on, but I didn't know when I started that it was important. So they told me I couldn't do anything or recommend anything that required a change in the law. So decriminalisation, legalisation. I was very relieved about that because that is a topic that divides people.
Yes.
And I really wanted to do a review that got us to a point where we could persuade the government to give us resources to improve life, treatment, recovery for people who are drug dependent. If I'd gone into all the bother of trying to study decriminalisation and legalisation, it would have swamped it.
Yeah.
The second one, I didn't understand how important it was. They said I didn't need to study the healthcare and drug care for prisoners in prison. They wanted me to look at how you prevented so many people going to prison. And they wanted me to look at the aftercare for people coming out of prison after being in there with a drug offence.
Yeah.
But as I finished the review, and slightly before that, it really is all a continuum, and in fact, if you think about it, a drug-dependent person who may have to go and serve some time inside is still the same person that is outside. So that was a mistake. I think I should have pushed back on that. It would have made it more complete.
One thing that I don't understand, I've worked in juvenile hall treatment for 7 years now, and one thing I just can't understand, and you might be able to explain it to me, is when people with a drug dependency go into prison, and prison have methadone programs, and they run, sex social groups and so forth, but then people come out still 5 years later, still on a methadone prescription, and I think surely that is the best time to tackle that problem in prison. Why do we? Do you know why we do that?
Well, I don't think it's an intention to do it. I think the real problem is they reduce the number of special wings in prison that were equipped and staffed to help someone become drug-free. But recently, with the money that has come through my review and the new drug strategy, and the Ministry of Justice announced last week that they're going to put many more special units in prison, because it isn't a quick and easy job.
No.
And you need to provide the right environment, and you need to be in prison for 1 or 2 years. You can't do this in 3 months.
Of course, yeah.
And you need an environment in which you're going to be able to help people train or find something meaningful to do, or hopefully do some work. So I think it was lack of resources, that the only thing they could do was give them a methadone script, which I absolutely agree with you is totally not what you want to see. So I visited Wormwood Scrubs about 6 weeks ago. That is a remand prison, so a lot of people churning through, very difficult for them. But in fact, the drug service there is short of about 9 key workers.
Okay.
That means they're stretched to their absolute limits. They know that. They can't recruit. And what I discovered, which I never knew, was if you're a drug worker in prison, you earn about £5,000 less per year than somebody working outside.
Yeah, that's interesting.
Now, there's a lot about supporting people in prison that needs to be changed. And it would have been nice to have taken a better look at them.
And to be fair, there's a lot more money coming into the system because of you and your research and your findings. What's that like? And how much of an impact you're making in the community because of the work that you've done?
Well, I'm delighted that they have given it resource, and they've given it resource for 3 years. I hope that that's going to make a difference. But money alone, doesn't make a difference. So if that money is distributed and we just do more of the same, and it's not used wisely by local authorities and all the other agencies who might benefit from it, then it won't have been worth it. So my greatest concern now is this money really going to start to turn the tank around? And are we going to see real holistic care? Are we going to find that providers don't do more of the same, but they really do develop a recovery program? Because one of the things I found in doing the research, whatever people tried to tell me, and they all tried to convince me how good their service was, but I knew the service wasn't good because of the stats in front of me. I mean, everything was going in the wrong direction. So are we going to really be able to get people treated initially with whatever pharmacological agent, if you like, the medical part of it? But then are we really going to develop proper recovery programs? Because recovery can take a long time. And if all you get is the medical bit plus a script, which is actually what's been happening, and if there are no psychologists to support you, and all the other things that needs to wrap around you, and if there's not safe housing, and if there's not the opportunity to work, and if the providers do not bring that stuff together and mental health support, it won't be any better than it is now. I can't do that.
Well,
I can only provide, I've provided the route map, but I can't, deliver it.
My concern was originally when we was told that X amount of money was coming into it, that we just hire X amount of new key workers. You spoke about that service having 9 less key workers than it should do. Caseloads now, when I started 7 years ago, there was around 50, I'd say, which was considered high then. And now we're talking caseloads of around 80. How do you deliver a real psychosocial intervention to somebody when you've got such limited time to see them? How do you help?
Can't.
You can't. It's impossible, isn't it? So I understand the need to invest in more key workers, but you're absolutely right. If we haven't got the base stuff right, if people haven't got stable housing and accommodation, we can't. If you look at the Maslow hierarchy of needs model, you can't get to that point of enlightenment, can you? If we don't have this basic stuff.
You can't go to work every day if you don't have somewhere to live.
Exactly. Yeah.
And you're not going to stay off drugs.
Yeah.
If you're being housed in a home or a house with somebody who's shooting heroin, you will shoot heroin. We're none of us that strong. It would be, it's simply not giving somebody a fair chance. So I will visit as many places as I can, and I will ask as many difficult questions as I can.
Yes.
But I can't change alone. I can't change motivation or determination to really deliver a high-class service.
How do you stay focused and ensure that your key messages stay at the forefront of the public's attention?
Well, first of all, you need to stay evidence-focused. I don't really want to talk about anything that I don't feel I've got evidence to back me up. So if you stay sort of focused on the facts, and if you then think on any interview, unless it's a long one, so for example, if you're doing the Today programme, you can only get over, if you're lucky, 3 messages, and you may only get over 2, but you've really got to not let them deflect you from what you want that audience to hear. And therefore you have got to work pretty hard to strip out all the unnecessary stuff, because you've got very little time on either television or on the radio.
Yeah. I often found that people with addiction are vilified in some forms of the media. People talk about the benefit system and how to sort of drain the benefit system just to spend money on drugs with a real lack of understanding. And I think one of the things that I want to ask you is, why was it important to you to spend so much of your time and effort and to do all this research to, I suppose, improve the lives of people that do have such a bad reputation amongst people?
I guess the simple answer to that is I've spent my life, my professional life that is, trying to improve the lives of people in various different situations. So the largest part of my professional life has been in medicine, and I specialised in an uncommon condition, which you won't have heard of, called scleroderma, which kills people, particularly women, which had very little research in this country or anywhere in the world when I got interested. And I set up the National Service and started the research programme in this country. I then went on with my job as National Director for Health and Work to really tackle the difficult problem of how do you enable people to stay healthy in work and enable more disabled people to be in work. And I include people with mental ill health. I like challenges. I'm not so good in the steady state. So this really is a fantastic challenge. I also felt passionately, strongly that drug addiction is a health condition, a chronic condition, just like you might have diabetes or rheumatoid arthritis. If you've got drug addiction, you may have relapses and remissions. The important thing is not to think somebody goes into treatment, tick box, we have done the treatment, which is what has been happening in this country. They're then sent out with no follow-up, often with not a programme of recovery. And I felt very strongly that we stigmatised people. The NHS, when they met the NHS, did not give them the same service that they would give you or I if we had a medical condition. And I really wanted to see if I could change it.
I think services could score CQC ratings of outstanding, good, whatever it is. But the reality to me, when I read that report, I just see that all their paperwork is in check.
And also the CQC is simply not good enough, because what they can only do is score the service you deliver. So if all you're delivering is a methadone service, as long as you're doing that correctly, you'll tick all their boxes.
Absolutely.
What they're not able to do is say, where is your mental health service, your trauma-informed service? What's your housing project like? How many people are you getting into work? Do you have a service for families? Show me your recovery program. All the things that really are important, they don't score. I mean, it was one of the things I have said absolutely needed change. Of course, to change it, I think to change it radically, you need to change the law. But I mean, everybody knows that this is an incomplete assessment of a service. And I really would never look at the CQC scoring to tell me whether a service was good. I talked to the people who have the service. And so when I was doing the review, all the providers told me how good their service was. When I talked to the people who were in the service, I didn't get many good reports. So, I mean, it was like chalk and cheese. And actually, you need to listen to the person in the service.
Carol, what is your favourite thing about your career today, or perhaps the thing that you're most proud of?
It's very hard because I've had a long career, but probably the work I have done for the disease scleroderma, because during my lifetime of working in it, setting up the service, working with international colleagues, I've seen the life expectancy of patients with that disease change and change dramatically. I've seen a disease which was hopeless become a disease which, for many people, you can control it. Can't cure it, but you can control it, and you can either give them many more years of disease control and a comfortable life, and in some cases you can really suppress it to such a degree that it's not a problem anymore. So it was a privilege to be able to be in something where you could physically see change and see people live who before would definitely have died.
Ignorant of me to say, but I've never heard of it. What is it, I suppose?
It's a disease that is a disease of a protein called collagen. You know, we're held together by collagen. That's the structure. Collagen makes up your bones, it's in your muscles, it's in your skin, it surrounds all your organs. It's sort of, if you didn't have collagen, you'd be like a jellyfish.
Oh, okay.
You know,
Yeah.
It's your structural protein, and it's very well regulated. So when you cut yourself, you heal by the body knowing to make collagen.
Oh, okay.
So it cross-links, it heals the skin, and then it stops because you've healed your wound. In scleroderma, it forgets to stop. The regulation of that protein has gone wrong, and you overproduce it, and so you turn to leather. So you can't, I mean, a scleroderma hand will look like that, and it changes you physically, it deforms you, but it kills you by overproducing in your heart and your lungs and your kidneys. So, and it damages your blood vessels. It's a horrid disease.
When conducting your research, was there anything that surprised you?
I think in doing this review, the extent to which addiction had really deteriorated in so many ways. I mean, the increase in the number of deaths, the violence associated with county lines, the children being dragged into gangs from really poor backgrounds. And I think the change in drug taking in young people was to me a great shock. So the biggest increase in recreational drugs is in the 16 to the 19 to 24-year-olds, and then the 16 to 19-year-olds. And when we looked at the figures, I mean, they're children absolutely as young as 11 and 12, taking recreational drugs. I think they were the things. I knew there was stigma. I knew people weren't well respected. None of that shocked me. I found the lack of, as you said earlier, of really good work in prisons deeply disappointing, because I've visited a few prisons. But I think it was the level to which addiction had completely sunk down in terms of support, treatment, prevention, etc.
I've obviously been around for doing this for 7 years now. One thing that I was always told when I first started was that heroin users were an ageing population. So I find it now shocking when I see people coming in as part of medically assisted treatment on methadone prescriptions that are in their early 20s. That's always still a shock to me, even after 7 years, when I see somebody coming in at such a young age with a heroin dependency. Not so much when it's recreational drug use, like we've said, if we have people wanting help with cocaine addiction. But yeah, I still find it to be quite shocking.
Well, again, it amazed me when very hardened drug users would tell you that they started at the age of 12.
Yes, absolutely, yeah. And it's the circumstances sometimes.
And to think that somebody's taking heroin at the age of 12, it just seems very shocking.
Yeah. Did you get, as part of your research, did you get much of a chance to speak to service users?
Yeah. Quite a lot.
What was that like?
Because, we could, in fact, I know it was awful that we couldn't go out in part 2. We could visit in part 1 because it was before COVID.
Yeah.
So I did actually physically meet service users then. And I found them particularly useful in prison to be able to go and talk to people who were there for a drug offence. But in part 2, in a way, doing it online meant I met more people.
Yeah,
because we could fix it up much more readily. I think the stories often shock you because they're so awful. They're so. You can't imagine that people have been put through what they've been through, and are still able to stand on their own 2 feet, and for many of them are coming through it, but their experiences, you don't want anybody to have to live. And they're so often, not always, but they so often go back to a very traumatised childhood.
You talked earlier about sort of employment in the sector, and I think it is quite difficult to recruit into this sector at the moment. Have you done any research around that?
Do you mean recruit workers?
Yeah, so recruiting staff into it. I think, because I'll be honest, I think Change Grow Live as an employer pays. You talked about prison workers being $5,000 under what community works on. I think Change Grow Live as an organisation do pay quite well, but recruitment is quite difficult to get people in.
I think if we could get a much better spirit and a feeling that something's being done about addiction, that the government is investing in it, that there is a future if you go to work in addiction, that we develop much better training programs. We are developing a proper workforce strategy.
Yeah.
I think then it will seem like a topic you would not maybe want to go and work in because people respected you. It had a future, and there was investment. I don't think that'll happen immediately, but I think that one, that will happen. I think two, we've got to be flexible and think on our feet. So rather than say, well, we're looking for a trained worker, what they've done for local councils in North London, the money they got last year before the 3-year money, when there was 80 million distributed, they put their money together and advertised for graduates in either psychology or criminology. Said, you don't need to know anything about addiction, we'll teach you on the job. Yeah. Now, you can argue and say, well, you're taking untrained workers, But actually, if you've got a motivated young graduate, you can probably teach them quite a lot. And then, of course, they may need to do a formal qualification. So I think there's got to be quite a lot of thinking outside the box.
I've done talks at our local university, and I often, and again, one of the things I often say to people is, look around you. There's 400 people in this room, all with a criminology degree, all with a psychology degree. What sets you apart from everybody else? And for me, it's experience. So volunteering is a big part of it. But I often found that some people, in the opposite way, come in with all these ideas that I'm going to help everybody get drug free, and the reality is, not everybody wants to get drug free yet. I think for some people, especially if they're experiencing things like homelessness, unstable living, self-assessment, and all that sort of stuff, their addiction isn't necessarily a priority for them to tackle at that point. And I think that's one thing that some people find it hard to understand, because, to think now if I had an addiction, that would be like my worst thing that I need to deal with. But the reality is, for a lot of people, that's not the case. They've got so much stuff going on that they probably need to tackle first before the addiction. And I think that can be like an emotional fatigue, I guess, feeling like people don't want the help, or I'm not helping the people that I thought I'd be helping, the job's not what I thought it was, and that sort of discourages people as well. So I think it's coming in with, I think the good thing about volunteering in drug services, and something why I'm really passionate about getting people to do it, is because you know exactly what you're dealing with.
And what you're coming into.
Yeah, so there isn't these sort of surprises 6 months down the line after you've done your training, you've come into the job and this isn't what I thought it was going to be. I thought I was going to help everybody,
Well, if you think about it, you don't help everybody with cancer.
No.
I hate to say it, but some people with cancer die. But that doesn't stop you trying to help the majority.
Absolutely.
Or at least even if you can only extend their lives by a few years. But there's this spectrum of that. There'll be a spectrum with drugs.
Yeah, absolutely.
And why would we expect it to be any different?
I often say, if I can help just one person, I've done my job. I think that's one of the things that I try to instill in volunteers, students, is if you just help one person, you're on the right track. And that's kind of just take it one step at a time, I guess. So one of my questions for you is, you've done so much. Have you ever to unlearn something in your line of work?
I didn't have a good enough concept of how long recovery could be, and what the process of recovery was, because of course most of my own thinking of being, albeit in chronic disease, it might be that your recovery period would maybe 2 years, but I had to learn that in drug addiction the recovery period may be life. You may say and be more comfortable saying, I'm a drug addict, I haven't taken a drug for 17 years, let's say, but I'm in recovery.
Yeah.
So that slightly different. I had to unlearn what I thought of was recovery in a more physical, ordinary.
Yeah, and I'm glad you said that. I went to it was a recovery convention, and they did a point where they asked people to stand up. Stand up if you've been in 25 years of recovery. Stand up if you've been in 20. And when people started to stand up after 20 plus years of recovery, my question was, when does recovery become recovered? And I found that interesting that people still identify as an addict, even after not taking substances 20 plus years later. Because I was thinking, again, my train of thought was, how do you know that you couldn't just have the one drink now after all this time?
I think they would tell you they couldn't.
Yeah, they would. And some people, one of my volunteers, I asked her a similar question before. I was like, how do you sort of assess your stability? And she said, the reality is, for me, she said, the risk is too big. She said, I know that, maybe she'd just been on holiday. She went on an first all-inclusive holiday in recovery. So she said, you can imagine the temptation was natural there with the bar and everything. And I said to her, did the temptation cross your mind? She said, of course, but she said, the risk isn't worth it. She said, talking about the recovery capital and the relationship she's got with her daughter, how often she gets to look after her grandchildren. I thought that was interesting, and that was something that, again, I agree with you, because that was, when does recovery become recovered? Do you know?
And I think it's perhaps more secure making for someone who's had an addiction to say, I'm in recovery. It's tempting fate to say I'm recovered. And that I think, that has been my learning as I've done the work.
So, Carol, when you looked at local commission services, what did you learn, I suppose?
Well, first of all, I found they varied enormously, from actually a few of them being very good to, quite frankly, being quite awful. And in the very good ones, there was a very experienced commissioner, a commissioner who understood the special nature of addiction. When it was bad, then the commissioner was commissioning all kinds of services, not just addiction. This was just one of the services, and they didn't understand any, probably, of their services very well. But to commission addiction well, it is quite specialised, because you've got to commission in a holistic way if you're going to do it properly. As I say, you've got to think about the, if you like, the medical treatment you need, the mental health and trauma treatment you need. How are you going to make sure you've got a good recovery program in there? Is it going to be possible to really get safe housing? And what about enabling people to volunteer or find jobs? A good commissioner won't necessarily commission that all from one organisation. I mean, they will look at where there is expertise in their area and think, what do I have to put together to make this good? And they will. And I was shocked that some areas had not done a needs assessment for several years. How do you commission if you don't know what your needs are? If you don't know how much heroin and crack you've got, or have you got a big problem with powder cocaine or ketamine or any of the other synthetic drugs, if you don't know what you've got there and how much alcohol have you also got in the mix, if you don't know your need, and then you don't have an understanding about how you commission the service together, what the worst areas were doing was putting very little money into it and giving the contract to the company that offered to do it for the lowest figure, without having any concern, as far as I could see, that you can't deliver a good service if there isn't enough resource in it, and if you're expecting a drug worker to cover 50 plus people. So it is a sophisticated and complex issue to do this well. And in the new local guidance to local authorities, the Department of Health and Social Care have spelt it out much more clearly with accountability. I could never find who was accountable. I would go and visit areas and say, who do I talk to that can tell me what is being delivered locally for your drug-dependent population? Who knows the situation? So the local council would send me to the Director of Public Health, and the Director of Public Health would send me back centrally to OHID, and OHID would send me to partly to talk to the NHS or to talk to the department. You know, I mean, I was just sent all over the place. Mm-hmm. It isn't good enough. I mean, somebody needs to be carrying the responsibility. So in the new guidance, one, there will be commissioning standards. So the government will know whether a local authority is commissioned according to the standards set. There is absolute guidance about how you form the right partnerships and how you do this. And there has to be a senior responsible officer to whom I, for example, could ring them up, or the Prime Minister could ring them up, or the Perm Sec could ring them up and say, tell me, what's it like in your local area? Who's delivering the service? How good is it?
That is the one thing I can come to back in my head is it because this person said they can do it for the cheapest?
Well, yes, that's what was happening.
Absolutely, yeah. And that means that services are getting worse and worse, which means it's having a knock-on effect for the service users.
And it drove very unpleasant competition.
Yes.
And then people got the service, then discovered they couldn't deliver.
Yeah, exactly. That's it, yeah.
I mean, you wouldn't do that if you were commissioning a breast cancer service, would you?
No.
So why are you doing it? For addiction? You're doing it because you could get away with it.
Yeah.
And you know, commissioning an addiction service doesn't win you local votes if you're a local councillor.
Yeah.
Building a new road or I don't know, a new school may.
And I think if more people understood the reality of what was happening under the surface, people's opinion would change. And that's why it's so important to have you come on today and talk about these things as well. So we do really appreciate it. So what is, going on the topic of this, what is the best piece of professional advice that you have ever been given?
It's a very interesting question. Probably the best piece of advice was given to me by a woman called Professor Margaret Turner Warwick, Dame Margaret, when she was the first woman president of the Royal College of Physicians. I followed her as the second. And she said to me, just go out there and be as good as you can be and really try to do what it is you want to do in medicine. Don't talk to me, she said, about being a woman doctor. Just talk to me about being a doctor and then go out there and be as good as you can.
Absolutely. Oh, thank you for that. Appreciate it. I also understand that you've just been reappointed as the chair of the British Library. Is that correct?
I have.
So what is next then, I guess?
I've got enough of them.
And that's what I was thinking, when we looked at how much you're doing, where do you go from here now?
No, I've got enough. I mean, I really want to see this 10-year drug strategy really make a difference. That really, that and the fact that I am going to do another 4 years as chair of the British Library is fantastic, and I love that job. I also chair one of the government's What Works centres called the Centre for Ageing Better, which concentrates on people between the age of 50 and 75, really thinking about what do you need people to be doing or thinking about in that period to make sure they can enjoy older life, whether that be what sort of home are they going to live in, their health, their ability to work, their community around them, the place they live in. And that's fascinating. I have too much to do, not too little.
Yeah. Yeah, if you don't get time to watch a movie now and again, I think that is a sign to me of how busy you are. Obviously, the work you're doing, we're going to see an influx in new staff members coming into this service. We talked also about students moving into the service, into this sector. Sorry. So, I suppose the question is, what advice would you give to people starting in the drug and alcohol treatment sector for the first time?
I would try to. Well, first of all, let me say, I hope they'd be working in an environment, in a culture that is going to give them the right approach, that will encourage them, that will enable them to train, that will make them see this as an exciting and worthwhile thing to be doing. But I guess my advice to them would be to try to understand that what they're dealing with are human beings who have got a health condition which is complex, because it isn't just like, let's say you've got diabetes and you're going to learn how to inject insulin and there are things you're going to do to be careful. If you're looking after someone who's drug dependent, you've got to think about all the other things they need around them. So you need to be able to understand you're in a complex environment, but to do your bit in partnership. You can't deliver a good drug service by being an isolated worker who doesn't appreciate all the other things that need to be brought together. So I think to really try to understand the person. Of course, if you've never been addicted, this is really quite difficult, but hopefully you're going to have peer workers with you to help you do that, or in the service there should be peer workers. But I think it is about having some humanity and empathy, but also there will be times when you need to be quite tough.
Yes.
It won't all be empathetic.
Of course. Thank you very much for your time. And again, the work you've done, this report you've done, I mean, I've already said it, but your name is in everybody's mouth. And I think you're going to change the lives of so many service users,
let's hope
so many staff. And I just want to say personally, thank you very much for all the time and effort you've put into changing this sector, because it is much appreciated. So thank you very much.
Pleasure.
And if you enjoyed this episode of the Believe in People podcast, don't forget to check out our other episodes and hit that subscribe button. Follow us on Facebook, Twitter, Instagram and TikTok. Our name is CGL Hull. That's CGLHULL. We're on iTunes, Spotify, Amazon and Google Music. So please like and subscribe to receive regular updates. You can also search for Believe in People podcast on your favourite listening device, and if you could leave us a review, that will really help us with getting our message out there and rising up the daily podcast charts.